Good evening, everybody. Welcome back, I guess, to week 2 of our tour through neuroanatomy. This week, we're going to go over the brainstem and some subcortical structures, and I'll touch on some vision pathways as well. My name is Michael. I am 7 days away from being a PGY2 neurology resident, and I've been tutoring with MST for about 4 years now. So before we get started with some of the neurology, I'll go over kind of who we are at MST. So we're an online one-on-one tutoring service that handles everything throughout the med-ed continuum. So from pre-med all the way through residency and even to some subspecialty boards. When you meet with a tutor for MST, you're sort of backed by years and years of tutoring success. So we all share tips and tricks with each other. And so some of those will be fed forward to you all tonight. And what we kind of have in common, this whole group down here at the bottom, we're med students, residents, attendings who've all done well in these exams, but really more than anything love to teach. So our agenda for tonight, I will cover some cranial nerves, some neuroanatomy of the brainstem, and try and really boil it down to how I will call it a minimalist approach to neuroanatomy of the brainstem that you can take with you on test day. We'll go over some of the vasculature, which will help you with some of the stroke syndromes. I will attempt to simplify the basal ganglia, and then I'll go over some quick things on vision and how the eyes feed into some of these mechanisms. And then we'll just round out the brainstem reflexes and talk quickly about coma and posturing as well. So, what I would encourage everyone to do in the chat, please, when I ask questions, feel free to type them in. If you have questions as I go, I will do my absolute best to get to them sort of in the moment when it's fresh on your mind. There will be kind of breaks that I put in the middle here and there, and I'll try and keep up and address things as we go. Okay, so I know the cranial nerves can be exhausting, and there's lots of big lists and tables and things. And so my approach when I work with students is always to talk. You need a nice basic groundwork first, and then we're going to layer kind of more and more complicated information on top. So I would tell you that this table needs to be fairly familiar to you, and I will just quickly go through it, right? So cranial nerve 1, the olfactory nerve, cranial nerve 2, optic, 3, oculomotor, 4, trochlear, 5, trigeminal, 6, abducens, 7, facial. You can read. Some tip that I would say is maybe for some people is helpful. A lot of people can confuse glossopharyngeal and hypoglossal. They don't remember which is which. Hypo as a root means below. So I think about things numerically down, right? Hypoglossal is going to be below glossopharyngeal on the list. So that can be helpful to separate them. We'll do function and everything, right? But this is where you have to start. You have to know this. There are mnemonics for this that I will not share in this webinar, but you have to know this list first. The next thing that I would tell you is just kind of get familiar with what the brainstem looks like, right? So we have the midbrain up here, we have the pons here, and then we have the medulla down here. And what we're going to start to do is just kind of label, and you're going to be expected to know where all of the cranial nerves leave the brainstem and sort of what they look like. So this one that comes here comes out in an X, which is the optic chiasm, is going to be cranial nerve 2. Then we're just going to count down. We're going to do 3, cranial nerve 4 wraps around the back. Cranial nerve 5 is huge and comes out of the pons. We're going to start back in the middle like we did with 3, and then sort of get into the 7 and 8. I then kind of sometimes get really confused down here with where certain things are coming from and what they are. The most helpful thing for me to do is actually 11 next, because it sort of leaves the brain from the spinal cord and not necessarily from the brainstem. So I sort of look for that to be the lowest. And then I look for 12. And then I would not promise you that I would always get it right between 9 and 10. Some images are going to look different, right? But I would tell you, based on kind of my understanding of the anatomy, that I would say that this one is 9. I don't really know how to explain that. And then this is 10 back here. But in general, right, I think if you recognize the chiasm and you recognize 11 and you recognize 5 coming out of the pons, those are my big, big landmarks and the ones that maybe you're more likely to be asked about. Just another view of the brainstem, this one being from the side. right? So we talked about 3 comes off in the front of the midbrain, 4 comes off of the back of the midbrain and wraps around. I'm always going to describe this structure as an egg. What is this egg-shaped structure that lives above the midbrain? This one right up here. Thalamus. Really good, Oliver. Yeah, awesome. Matthew, the mammillary bodies are going to be way smaller than everything else, but good guess. I'll point out 1 or 2 other kind of anatomic features just of the midbrain, really, actually, in this cross section. So you have these little bumps right here. This is going to be the superior colliculus. I'll just write SC, and this is going to be the inferior colliculus. The pons, this structure, right, all right here, has these pathways that are going to feed backwards into the cerebellum, and those are going to be the middle cerebellar peduncles. So if I have my fist being the pons, my finger, right, kind of is going to be the middle cerebellar peduncle on both sides, sort of wrapping around the front. Great. Cranial nerve 4, again, notable. It's the only one that leaves the brainstem from the back. I think this image is, again, it's a little, makes it look like this is, but this is actually coming off the back of the brainstem, and it's the only one. Okay, so what I want to do now, right, again, we're going to kind of go slow through this. And like I said, I'm going to add a lot more detail as we go. So I want to make sure that everyone's comfortable with sort of the early stages. So cranial nerve 2 is above the midbrain, right? So we're not going to be able to place that. Cranial nerve 3 is going to be in the midbrain. And then if you want to be very fancy, it's going to be at the level of the superior colliculus, right? So if we look backwards here, cranial nerve 3 is going to be in the midbrain at this level, and cranial nerve 4 is going to be in the midbrain at the level of the inferior colliculus. To make everyone's life easier on the next, we're just going to draw them both, right? So we're going to draw 3 and 4 here. We have 5, 6, 7, and 8. You'll see there's a kind of a method to my madness on how we're going to draw these, right? But we'll just draw 5, 7, 8. I mentioned that 11 is way down below the medulla. 12 is in the medulla. 9 and 10. Okay, so I did that kind of quick, but what I wanted to go over with this slide is more than just the cranial nerves, right? So we've talked about a couple things, and so I'll have everyone actually fill out this poll. So before I get going with some more things, have we heard of the rule of 4s? This is a trick for remembering brainstem anatomy. And I'll keep that poll open for maybe like 10 more seconds. I'm not going to be testing you on it, but is it familiar or unfamiliar is really... All right. Yes, and okay. All right. So a good portion of people have heard of it, and some haven't. So I'll go through that kind of on the next slide. But what I wanted to just, again, quickly go over is if anyone participated last week in sort of how we recognized the cervical spinal cord as having sort of the thinnest gray matter and the densest white matter. So I'd say the thinnest H in the center. Then the thoracic spinal cord had the lateral horn, and that was our identifier there. And then the lumbar cord was sort of the one that was left over, but maybe it was thicker and smaller altogether. I would encourage you to kind of look at my simplified drawings of each of these structures and sort of keep those in your mind, right? So the midbrain is, I'm going to always draw it sort of as these like upside down Mickey Mouse ears with the cerebral aqueduct in the back. The pons, I'm going to draw a little box here with the fourth ventricle closed and really nothing noteworthy in the center, right? So the pons is almost going to be one you're going to be like, okay, if it's not the midbrain, it's not the medulla, then it's the pons. The medulla I'll typically draw with this structure in the back being open, which is the fourth ventricle. And then these sort of curvy lines down here, which is the inferior olivary nucleus, which you don't really need to remember anything about from a function standpoint, but helps you know, hey, I'm in the medulla. Obviously, these are just looking through these sections at one point, right? I would say that's probably even a little low for where I drew through medulla, but it's going to change throughout time. You really just need to have one good impression of each. Okay, so now with the rule of 4s, I'm going to talk about them briefly and try and simplify it. And there are 4 rules, and I'm going to hopefully make an argument you really only need 2 of them, right? If you're like, Michael, I cannot remember 4 rules for the test, I've got space in my brain for 2, if any. So this was, again, it just was an original paper from 2005, trying to teach people how to recognize brainstem strokes and remember the anatomy. I think that most students could do most questions, right, with just 2 of them. And the one I want to focus on is there are 4 cranial nerves in the pons. And then note, there are 4 above the pons. They're not necessarily in the midbrain, but they are above the pons. And then there are 4 below the pons. So I think that's the most important rule. And if you think back to our last slide, I put 5, 6, 7, 8 in the pons, 3 and 4 in the midbrain, 1 and 2 are higher. And then I put 9, 10, and 12 in the medulla and 11 below. The next most important rule to me is that the nuclei that divide evenly into 12 that are in the brainstem, right, so that excludes 1 and 2, are all going to be in the midline, right? So that's going to be 3, 4, 6, and 12. And I'm going to make the argument that you can get most all questions right just with those 2 rules. If you're going to learn a third one, it would be the next that I put in the row, is that the 4 midline M structures. So the motor nuclei, which is what we've just talked about in rule number 2, the medial longitudinal fasciculus, which we'll talk about later, the medial lemniscus, which is the continuation of the dorsal columns from the spinal cord, and then the motor pathway itself, right, which we would call the corticospinal or the corticobulbar tract. The one that I would almost, I don't want to say ignore, but I would expect you to use less often is that the side S structures, right? So the spinothalamic tract, the sympathetic pathway, the sensory nucleus of 5, and the spinocerebellar tract, which I wouldn't say is going to have a lot of complicated clinical correlation for you all. So I think you could just remember that sensory stuff is on the side, and that might be the easiest simplification of this rule. Okay, so let's go through and let's apply this, right? Sort of how we did the last time. I sort of already did it, but right, the nuclei for cranial nerve 3 and the nerves are going to be in the midline. And then just imagine we come down a little bit, and then 4 are also going to be in the middle, and they're going to leave out the back. Okay, that's all we have in the midbrain. Cranial nerve 6 is going to be in the midline in the pons, and then I layered them all out here. 5 is very complicated, right? 8 and 7 are all going to be out on the side. And then 12 is going to be in the midline. I'm going to leave in the front. And then 9 and 10 are going to be out on the side. I would say that if this is where you want to stop with brainstem anatomy for step 1 and step 2, I think you could limp through most things, and I would fully support that. I'm going to add in a few more things as we go that hopefully will be helpful. So the next I would want to talk about is function, right? So if we have a basic understanding of what the nerves are and where they are, then we can start to talk about what they do, right? I think skipping to what they do or what foramina they leave the skull is going to make it harder for you to remember these things. So I'm not a big mnemonic person, but I do particularly love the mnemonic, right? The some say money matters, but my brother says big brains matter more. That, at the very least, will help you sort of just layer out whether or not these nerves cover senses, motor, or both. Yes, it is a real life statement, and it is also, again, it's a helpful mnemonic, particularly when you have to remember 12 things and what they do. So olfactory, sensory only, smell. Optic, sensory only, vision. Oculomotor, motor only, eyes. Trochlear, motor only, eyes. Trigeminal does both motor and sensory functions, right? So we think of trigeminal, I will always sort of put my fingers on my face like this, right? We have V1 branch, which does sensation up here, V2 branch, which does sensation throughout the cheek, and then V3, which does the chin. It also has motor output to the muscles of mastication, and that's going to be through the V3 branch. So I think that just kind of thinking like this, and maybe picturing your own hand or my hand right here would be helpful in remembering that it also has some motor function to the muscles of mastication. What I want to comment on while we're talking about the trigeminal nerve is I want you to just think about all of the little spots on your face that need sensory input. So the trigeminal nerve is going to effectively have a tiny little nerve traveling everywhere in your whole face. So it is an excellent highway, right? It has roads that go everywhere. A lot of students tend to think the trigeminal nerve has lots of special powers, like it helps with taste, or it helps with salivation, or it helps with lacrimation. It does not, right? It does not do any of those more fun things, but it does provide nerves that some of those more fun things like travel along. So you're going to see lots of things labeled as like the greater petrosal nerve. And I would just, it's never going to be the trigeminal nerve that's doing that function. It's going to provide some of the structure. So hopefully that makes sense. Circling back to the list, 6, motor only eye movements, right? So I would just encourage you 3, 4, and 6. Right, the clinical correlate here is if I have a cavernous sinus thrombosis. Cranial nerves 3, 4, and 6 all run through the cavernous sinus. So what will that person's eye do if they have a thrombosis of the cavernous sinus on that side? Matthew says no extraocular movements, and I would agree, right? If you knock out one of them, you're going to lose some particular movements. But if you have a clot back in the cavernous sinus that's going to compress all 3 of them, your eyes are not going to move at all, right? So these are the only ones that are going to really move your eyes in a purposeful, voluntary way. I'm going to star 7 because 7 is one of the most complicated, and I'm going to give 9 sort of that biggest designation, right? So if you have to say, all right, these 2 are going to take me the longest to learn, I think 7 and 9 are going to be the ones that have the most function. If I had to boil them down, right, because it's going to have both. So facial movements is the main function of 7. It also does have special powers, right? It does do taste, does lacrimation, and it does salivation. And it does have some motor output, right? So it does the posterior belly of the digastric and the stylohyoid muscle. And the one that I want to talk about is the motor function to the stapedius. Because some of you are going to see this. So remember, we have 3 tiny bones in our inner ear. And effectively what happens is one bone will vibrate against the next bone, and then that'll vibrate against the next. And so the stapedius muscle, right, is by cranial nerve 7 and will sort of hold some tension so that vibration is not too much. If the cranial nerve 7 input to that muscle is broken, right, that muscle's not working, then the bones will oscillate more widely and people will have hyperacusis. Sounds will appear extra loud to them. And then Dushan is bringing up an excellent point that I glossed over and that I usually make after I cover cranial nerve 7 because I feel like it's tested less frequently than the hyperacusis of cranial nerve 7. So 7 does stapedius, and T for trigeminal does the tensor tympani. If you lesion the tensor tympani, then people have hypoacusis. They have a harder time hearing sounds. And that I want you to think about like a drum. If the drum is not taut and you hit it, it's not going to make a lot of sound. So when that muscle goes away, the drum sort of falls in and then sounds appear more dull. So the way that I keep that straight is 7 to stapedius, and then I think about if the bone is moving more, sounds are going to be louder, and that's hyperacusis. Trigeminal to tensor tympani, and then I think about a drum, and then kind of like a sagged drum is not going to make as loud a noise. But yes, excellent distinction there. 8, vestibulocochlear nerve. The vestibular aspect of it is going to do balance. Cochlear is going to do hearing. 9, glossopharyngeal. I would think of it pharyngeal movement, right? So usually afferent limb of the gag reflex is sort of the classic teaching, swallowing, right? Coordination. It also has taste function, right? So posterior 1/3 of the tongue is by the glossopharyngeal nerve. And then remember that it does some baroreception, right? So it senses pressure exerted on the carotid body. So if you have high blood pressure sensed by the carotid body, the glossopharyngeal nerve will tell the medulla that either your blood pressure is too high, which will then tell the vagus nerve to slow the heart down, right? So it will provide sort of the parasympathetic outflow. I would tell you that if you're ever going to be tested on this reflex, you're going to be tested on the glossopharyngeal part of it. Because if you think about the aortic arch, the vagus nerve provides the input, and the vagus nerve, it's the afferent and the efferent. So that's not a fun test question, right? You wouldn't really have to know anything. You could just guess vagus. So usually they're going to test that you know that glossopharyngeal is involved here. Vagus does everything, but I'll focus kind of what it does mostly up top, and then it obviously has lots of functions in the cardiovascular gastrointestinal system. Palatal movement, absolutely, more so than pharyngeal. Does swallowing, the efferent limb of the gag reflex. Typically does sensation down in the throat. So when I think about the cough reflex, I think more vagus. Does taste. The recurrent laryngeal nerve is a branch off the vagus nerve, right? So it helps with speech. And then I mentioned the baroreception of the aortic arch. The accessory is my least favorite cranial nerve because it's not a cranial nerve. It's in the spine. It's in the cervical spine. But yeah, motor to the sternocleidomastoid, so head turn, and then trapezius for shoulder shrug. Hypoglossal is going to do tongue movements. It's going to innervate all muscles of the tongue, I would say, with one exception. And these are those anatomy questions that you get on UWorld and then roll your eyes and move on. But the way that I remember it is that the vagus goes to the palate. So palatoglossus, glossus meaning tongue, is the only one that's going to be sort of not covered by the hypoglossal. Great. There are more functions to all of these nerves, but if I'm trying to simplify this to a table that's not going to make you sort of cry when you see it and feel like you have to memorize it, that's how I would walk through it. All right, let's go over some of the vascular supply to the brainstem, and then I'll go over, so we're just gonna get, okay, so I'm gonna pause. Yeah, let's pause right here. All right, so we have these two arteries that you can see right on my cursor that come together and form this artery that runs along the front side of the pons. What's this big singular artery that runs along the front side of the pons? That would be the landmark. Yeah, Crystal, awesome. Arnon, everyone, great. So yeah, the basilar artery. And the basilar artery is fed from the vertebral arteries, right, on each side. And the basilar artery, you're gonna learn, is gonna put a bunch of feeders off into the pons. It's gonna put some arteries back that are gonna go towards the cerebellum. And then ultimately the basilar artery, I think this is going to give us a little upside down view here in a second, maybe. So the basilar artery is ultimately going to end and split back and become the posterior cerebral arteries. So that's sort of in contrast to these two, I would call them larger, juicier arteries that are going to run up, not necessarily along the course of the brainstem, right? So they're going to be more anterior, so I would call them the anterior circulation. And they're going to ultimately become the ACA that comes up like this, and the MCA that comes up like this. So these are the carotid arteries. So here people talk about the anterior circulation of the brain, which is the internal carotid arteries coming to the circle of Willis, but ultimately becoming the MCAs and the ACAs. And then the posterior circulation, which is the vertebral arteries joining into the basilar, putting off ICA and PICA in the superior cerebellar artery, and then ultimately splitting to become the posterior cerebral arteries. Great. So the circle of Willis sort of connects all of them, right? They all sort of form so if I occluded someone's carotid artery right on the right side, ideally blood from the left side would make its way across through that little circle. And so there's lots of pathologies of the circle of Willis that I'm not particularly going to cover tonight. We can talk about maybe one that might be relevant to, let's say that someone has a cranial nerve 3 palsy. Which area of the circle of Willis would I be most concerned about if I told you it was a vascular cause of their cranial nerve 3 palsy? So the midbrain would be a great place to think about cranial nerve 3. I already told you that's where it lives, right? So the nucleus lives in the midbrain, and the nerve is going to leave, and it's going to sort of travel through the brain. And there's an aneurysm of a particular artery in the circle of Willis that can compress on that. It is not the superior cerebellar artery. It is not the basilar. It's not the ophthalmic, but ophthalmic does blood supply to the retina, so good to think about with the eyes. ACOM is a common site of aneurysms, but not the one that's going to cause this problem. Yeah, PCOM, awesome. Matthew and Oliver. So an aneurysm of PCOM, so cranial nerve 3 is going to leave the midbrain, and the part of the circle of Willis that's going to kind of line up right next to it is going to be the posterior communicating artery, and an aneurysm of this one will press on this nerve. Great. We will move. Okay, last week I just did a basic overview of the tracts. I'll quickly move through it, but we talked about the ascending pathways. I want you to think of sensory information going to the brain, right? So the spinothalamic tells you where it's going. It's coming from the spine to the thalamus. It's also called the anterolateral system because of where it lives in the cord. There's pain and temperature, and it's 3 total neurons. So the first one is going to enter the spinal cord, going to synapse, it's going to cross, it's going to ascend some levels, and then it's going to run up the opposite side of the cord, make it to the thalamus, to the, which nucleus of the thalamus? Good, Oliver, so the VPL. And then we'll distinguish that from something else. So it's going to go to the VPL and then VPL to the sensory cortex. The other ascending pathway is the dorsal column, also which becomes the medial lemniscus. You'll hear it called the posterior columns. It does vibration, proprioception. Those neurons are going to come in the dorsal aspect of the spinal cord. They're not going to cross over immediately. They're going to ascend immediately. They're going to make it up into the nucleus cuneatus and nucleus gracilis of the medulla. They're going to synapse. Those ones are going to cross over. They're going to ascend the medial lemniscus to the brainstem, which we'll outline, make their way to the thalamus, also go to the VPL to the sensory cortex. So you have to remember all the cord stuff, how it travels through the brainstem. The descending, it's going to be things from the motor cortex down through the internal capsule. Internal capsule is going to effectively always run sort of down the anterior aspect of the brainstem, right? So the anterior aspect of the medulla, the anterior aspect of the pons medulla, and then it's going to ultimately become the lateral corticospinal tracts, and then make its way to the ventral horns of the spinal cord. So we have to know where all of these things are in our brainstem, and then we have a couple brainstem tracts that we'll add in, hopefully not too many. So, and then Dushan, you clarify, third total nucleus. So for spinothalamic, 1 neuron comes in the cord, synapses immediately. Neuron number 2 travels across, goes up to the thalamus. Neuron number 3, thalamus to cortex. Dorsal column, neuron number 1 comes in the cord, goes all the way up to the medulla. Neuron number 2 crosses midline, goes up to the thalamus. Neuron number 3, thalamus to cortex. Corticospinal tract is a 2-neuron system. Upper motor neuron starts in the cortex, does the whole journey, travels across the medulla, all the way down to the lower motor neuron in the anterior horn of the spinal cord. Okay, so I sort of talked about this last time. Corticospinal is always ventral-ish. And to give you just the words, corticobulbar, bulbar means brainstem, right, is the equivalent. So it's the upper motor neurons going to the cranial nerves, right? So it's motor to cranial nerves. And it should just sort of say, yep, it's coming from the cortex to the brainstem. Lemniscus means ribbon, so this thing's going to twist around a lot as it moves up, but it's medial. So that's all I would really worry about. It's going to always be in the midline M. And if you want to be very fancy, but I would ignore this fact if you do not want to be fancy, is that the sort of cranial nerve 5, which does all the sensation of the face, counterpart is the mesencephalic nucleus, which also starts with M. So I find that helpful. The spinothalamic tract is one of our S structures. So it's going to kind of run in the side of the brainstem. And then its comparison is the spinal nucleus of 5. Same information, pain and temperature about the face. Okay, so let's fill in the midbrain. We've already done cranial nerves. We have a couple other tracts and structures to fill in, right? So it would be helpful if everyone did this. I think if you did it, it would be nice, right? So I think about 3. I think 3 is always going to be sort of drawn like this. These structures down here, which I'm going to outline in a highlighter first, are the cerebral peduncles, right? So when the brain sort of comes down, it's going to be right in the front, and they're going to look like this. You will read about cranial nerve 3 leaving in the interpeduncular fossa, so inter being between the peduncles. All right, so the highlight is kind of helping me. I'm going to fill in. There's usually a stripe of some color here in the midbrain. What structure is that? Good, the substantia nigra, right? So you're gonna see this nice stripe of color, the substantia nigra, which we'll talk about when we talk about the basal ganglia. I'm also gonna put cranial nerve 4 in here. It'll do its little journey in the back. Remember, this is the cerebral aqueduct. Again, just like other things that could potentially show up on tests. This area around the cerebral aqueduct is called the periaqueductal gray, and it's named, it's a long name, but it's nicely. What is the periaqueductal gray involved in? This is not an easy question. It's one of my harder ones. You're all doing so well, but I needed to throw in some. So the periaqueductal gray is sometimes implicated for pain. So if you ever see periaqueductal gray, just be like, okay, pain. Like if that's part of the answer, just pain perception. It's just important for pain. That's about my understanding of it as well. All right, back to our tracts. So I mentioned that the corticospinal tract is always going to be anterior, right? And so it's going to run in the cerebral peduncles, and I would not worry about the organization. Okay. I mentioned that the spinothalamic tract is always going to be a little bit more lateral. And I would sort of just tell you that eyeballing it, it's going to be out here, right? So I will put ST for spinothalamic. I will put CS for corticospinal. And then the next one I have to think about is the medial lemniscus. It's sort of the weirdest in the midbrain. It's not as medial as I want it to be, given its name. So there's a structure here, it's the red nucleus, which again, we might touch on later. And then the medial lemniscus sort of runs right next to it. So these three sort of form like a little pathway. I always think of the red nucleus, they want to be medial, but the red nucleus pushes them a little bit out of the way. So that's kind of how I remember where those are. This is it. There's other stuff in the midbrain, right? So this would be lots of other, when you see pictures, right, these would be the colliculi back here. You have cerebellar peduncles. This is not fun to memorize. This is where I would stop. I think you can get through most things with this. Questions here? As I erase it. All right, the Pons is complicated, as all of it is. The same rules that we talked about on the last one still apply. The corticospinal tract is going to run in the anterior aspect, right, up near the front of the Pons. The spinothalamic tract is going to run out at the sides. The medial lemniscus is going to run, I think I drew it in pink last time, in the middle. Okay. So there's two, there's one on each side. So that's where those go. And remember, we have a couple nuclei to deal with. I will put a 6 in the midline, right, because it's one of the ones divisible into 12. 7 is on the side, and then 8 is on the side. And I know some of you are going to say, well, what about 5? 5 is everywhere. 5 has multiple different nuclei. 5 is everywhere. If a question is going to ask you to pinprick a particular nucleus of cranial nerve 5 in a particular location in the brainstem, that is a question that would stump most neurology residents, I would say. Like, I think it's far beyond what you would need to learn for either of these two exams. One thing that's kind of fun, so the nerve of cranial nerve 7 does a little loop-de-loop around cranial nerve 6, so sometimes that can help you know what's going on. And then 6 sort of leaves, I'm not drawing great to scale. And then 8 leaves out the side, kind of like we saw about. And then remember that front view of the brainstem, I had said 6 leaves in the middle, then 7, and then 8 more out towards the side. Okay? That's all I would do for the Pons. Remember, this is the 4th ventricle. There is more. This is the minimalist approach. Actually, since we talked about it, the other M structure, the medial longitudinal fasciculus, is back up here, back by the 4th ventricle. And I'll talk about what that does later. Okay, so the midline M structures, right, are motor pathways, our medial lemniscus, our motor nuclei, and our MLF. One more. Bear with me, and then we'll do some application stuff. The medulla, the open fourth ventricle in the back. I always think sometimes it's like drawn with like a Batman shape of like wings. That's sometimes how I pick it out, but the inferior alveolar nuclei. All right, I hope that you all can predict that some of the most anterior parts of it are going to be where the motor pathway, the corticospinal tract lives, right? So it continues. The rule is pretty surefire that if you have to pick one for motor, it's going to be more anterior. The spinothalamic tract, right? So also sometimes called the spinal lemniscus, is going to sort of be out here on the sides, much like it is everywhere. The medial lemniscus is again going to be in the midline. Is there an easy way to remember the fossas each cranial nerves leave? I hope you're not going too far ahead. Yeah, so we're going to circle back to a picture of the brainstem, and I can kind of go through that. There's a couple tricks, but there's not a great one. I wish there was a good central one. Just to be complete, I'll put the nerves that we've talked about. Remember, 12 is evenly divisible into 12, so 12 is a midline motor nucleus, and it's going to leave. And then out here, we have sort of what you're going to see with the vagus nerve, right, is you have like the nucleus ambiguous and the nucleus solitarius and the dorsal motor nucleus. So you're going to see a bunch of different lines all coming from different nuclei that all become 10. And then sort of buried within all of those, you'll also get like a little one that comes off for 9. All right, so that is how I would simplify. And then for completeness, right, same as above. The medial longitudinal fasciculus is like tiny up in the midline near the ventricle, but you're never going to be tested about that in the medulla because it doesn't do what you learn it for, which is we learn it for vision, but it does more stuff, but you only have to know it for vision. Okay, all right, so hopefully those like most important, right? So level 1 is just recognizing that I'm in the midbrain, I'm in the pons, I'm in the medulla based on shapes. Number 2 is if I'm in the pons, there's only 5 nuclei or 4 nuclei in here. If I'm in the midbrain, there's only 2. If I'm in the medulla, there's 3. 3, 4, 6 in the pons, 12 in the medulla are all in the middle. So the reason that I go through this kind of so painstakingly is if I tell you about a stroke that is affecting cranial nerve 9 and 10, right? Even if it's affecting a whole bunch of other stuff, you should be able to tell me where it is, right? You should have your kind of champion clues. Right? If it's affecting the nucleus of cranial nerve 9 and 10, it has to be in the medulla. If not 12, then it's not midline. And Ashton has it perfectly, it's in the lateral medulla, right? So the reason that I really painstakingly go through this is because it's going to help you sort through questions. And what do you know, right? So you're going to get this patient about this question about a 75-year-old female who's brought in with complete right-sided body weakness and loss of vibration sense and some other symptoms and blah, 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 blah. Their blood pressure is this, and you're going to be sort of overwhelmed with how much you're reading. Whenever I read questions about strokes for step 1 or step 2, I look particularly for 2 things. And I think it's in the brainstem, but I should clarify that. I look for how they describe tongue deviation, and then I look how they describe cough and gag. Because I'm going to tell you, I almost always think that they're going to give you questions about the medulla, and I can explain why. And then I really just need to know if it's median or midline or lateral medulla. All right. So for this person, I gave you right-sided body weakness, but I did not tell you where the tongue deviates. So Matthew has guessed the left side medulla. So we have alternative explanations. And then Matthew, I'll just ask you to clarify. Do you think this is a midline medullary stroke or is this a lateral medullary stroke? I will clarify, she has no abnormalities, she has no hoarseness, she has no loss of cough or gag reflex. All right, so I have a couple votes for lateral. I know, and then Ashton's like, well, and now that you say that, like, why medial? So why, I just, going back to the rule we talked about, right? So, okay, I agree with you. You're telling me that we are in the medulla, right? I think that's a great guess. So we're going to hit the corticospinal tract before it's crossed. So it's going to affect the opposite side of the body. Perfect. We're going to lose vibration sense. So that's covered by which column? Good, Demon. The dorsal column medial lemniscus. Is that a midline or a lateral structure? Midline. It's an M structure, so it's in the midline. And then we're tongue deviation, right? So we're motor nucleus of cranial nerve 12. So the motor nucleus of 12 is also a midline structure. So I would support this being a medial medullary stroke or midline medullary stroke as opposed to a lateral, right? Lateral is going to preserve, you're not going to have tongue deviation. You can have weakness and things like that, but they're going to emphasize sensory symptoms, right? So they're going to talk to you about the Horner syndrome on that person's side, or the loss of pain and temperature, or the ataxia from the spinocerebellar tract. But I didn't ask you to memorize all those. I just basically asked you to remember, is it in the middle? And if it's not in the middle, then it's on the side. All right. So I think this person has a left medial medullary stroke. So I would encourage you all, when you suspect a brainstem stroke, to see how they describe tongue deviation and then the cough. That's my tip. Just look at those two. All right. It can really, and then if they tell you all that's normal, then it's not a medullary stroke. And then they're going to tell you something about the eyes, and it's going to be in the midbrain, or something else that's going to be in the pons. Okay. So someone asked earlier, they suggested, Auburn was talking about which way does the tongue go? So this is a left medullary stroke. Is this tongue going to go to the left or to the right? Left. Ipsilateral. Left. Great. Does it always lick the lesion? Do left-sided cortical strokes cause left-sided tongue deviation? Auburn says no. Yeah, so I think that's something that's taught really commonly and can sometimes get you in trouble, but for most times on test will be okay. So you tend to, I would say, lick the side that is weak, right? Which is a slight adjustment. What I want you to think about is if you had a rolly chair in front of you, right? And you pushed both sides of it, the chair would move forward. If you took out one arm and pushed, that rolly chair would move. That's how our tongue works, right? So both sides are going to push out. If I weaken one side, the tongue is going to deviate to the side that is weak. If I have a lower motor neuron lesion on this side, this is my left hand, the tongue is going to deviate to the left because the right side is going to disproportionately push it across. If I have a left-sided stroke up top that impacts the upper motor neuron fibers that cross and go to the right side of the tongue, I theoretically could, it's less common, but it's possible. So that's the only reason that I want to be a little complete about that. But yet most of the time you are going to lick the lesion for a lower motor neuron. Does that make sense? But yes, this is going to be what I would anticipate to be left-sided tongue deviation. So the opposite of uvular deviation. Okay, so uvular deviation is only going to happen with cranial nerve 9 or 10, right? So it's going to be a lateral medullary stroke. And what I want you to think about is that normally our palate should raise, right? And so the uvula, I'm going to hang in the middle, should raise symmetrically. If I ask someone to go, ah, and they have palatal weakness on one side, right, and it's not going to raise, the uvula is going to deviate. A little different than tongue deviation. Does that make sense? So these two should both go up together. If one of them doesn't work and just one goes up, my uvula is going to deviate. Great. And then I've already covered this. This person does not have an abnormal cough or gag reflex, right? So this is a medial midbrain medullary stroke. It's going to be, those are lateral symptoms. Okay. I did not go through all of the I'm going to pause on this slide. I did not go through all the vascular anatomy of the midbrain because here's why, right? So medial midbrain and lateral midbrain, right? We can sort it out with the symptoms that we've talked about. What artery supplies the midbrain? I apologize for not having a slide on this, but hopefully this makes my point kind of clear. Higher than the basilar, lower than the MCA. So remember we're talking brainstem. So this is going to be either the vertebral arteries, they come together in the basilar, they split back into posterior cerebrals, and they've got some feeders that come off along the way. Yeah, so I think PCA or superior cerebral artery or something like that would be an acceptable answer. And that does the medial midbrain and the lateral midbrain. So again, if I was going to write a test question to make you all unhappy, which I feel like most of the time that's why test questions are being written, I wouldn't give you a midbrain stroke because you only just had to remember one artery. It does the medial midbrain and the lateral midbrain. Same for the pons. The basilar artery supplies the medial pons and the lateral pons. And that's no fun either, because then you don't have to remember any differences. The medulla, however, is different vascular supply in the midline than it is laterally. Does it kind of make sense? So we're below the basilar, right? So I want to make sure that we have like sort of spatial anatomy correct. This is not going to be the right. So the basilar, oops, that's wrong. The basilar is going to be like this big bulking thing. You're always going to see sort of at the anterior aspect of the pons, and it's going to provide like some feeders that come in, right? I want you to sort of picture, I don't know if this is going to be anatomically correct, right? But there's vertebral arteries that are going to come together at the medulla to form the basilar in front of the pons. And then they're going to split afterwards, and they're going to kind of run backwards. So I know that the drawing is a little not built for this. So the midbrain, the midline of the medulla is often going to be described as an anterior spinal artery stroke, right? So the vertebral arteries come together and form the basilar going up and the anterior spinal artery going down. So like my bottom fingers of the diamond here. And that often is sort of what you'll see in the mid. And then you have some branches, typically pica, the posterior inferior cerebellar artery does the lateral medulla. We're not covering a lot of vasculature, I apologize, but that's my argument why almost all questions about brainstem strokes are going to be on the medulla, because you don't have to memorize any differences for the other two. So wouldn't say ignore them, but focus most of your effort on what the medulla does. Okay, we're moving from probably, I would say, everyone's least favorite topic, which is brainstem anatomy, to their second most least favorite topic of all time, which is probably the basal ganglia. Most of what you're gonna have to know for the basal ganglia is not necessarily the anatomy and all the pathways. It's more sort of the pathology, right? Things like Parkinson's disease, Huntington's disease. I would love to talk about those much more than I would love to talk about anatomy, but we're gonna do the anatomy today, and then hopefully another time we can do some of the path, and I'll try and work it in here. I want to go over this first, which is just what does dopamine do in our brain, right? Because some of what we're going to be talking about today has to do with dopamine. And then hopefully this will help you with a little bit of neuro review and maybe a little bit of psych. I love teaching this. I don't feel like people typically talk about these things. Okay, so dopamine sort of does a bunch of stuff in our brain, right? So it has a mesolimbic pathway, right? So meso makes me think like kind of coming from the middle, like wherever we are, to the limbic system, right? So we have this area, red is not the right color here. So we have this area here, right? So the cingulate gyrus and the limbic structures, right? So that sort of does emotions and things like that. We have mesocortical projections, right? So out here to the frontal lobe, and we talked about last time, executive function, planning, motivation, things like that. We have dopamine that goes in the nigrostriatal system from the substantia nigra to the striatum, which I'll talk about in just a second. And the last dopamine pathway is the tuberoinfundibular, right? And so remember that the infundibulum is the name for the pituitary stalk. So this has to do with dopamine release to the pituitary stalk. And Matthew has correctly predicted where I'm going with this. And this is going to matter for things like prolactin. Great. So just to highlight those words, they're kind of nice. They tell you where it's coming from and where it's going, right? Limbic, cortical, nigrostriatal, infundibulum tells you it has to do with the pituitary. Okay. Let me clear all my drawings and move on. All right, so let's talk about the basal ganglia. I would say if you just had to simplify it to like, what does it do? It helps modulate voluntary movements, right? So when I'm making purposeful movements, and it also helps with emotions too, sort of, because if you think about it, we talked about how all those things are real close by in the middle. Just to name things, the striatum is the caudate and the putamen. The lentiform nucleus is the name for the putamen and the globus pallidus. That has some clinical relevancy. Sometimes, you know, when you like know the answer on UWorld or wherever, and it's just not written in the way that you have seen it, right? So instead of writing Wilson's disease, they write hepatolentiform degeneration. Yep, lentiform is in reference to the lentiform nucleus. Wilson's disease does preferentially affect this part of the brain. And then remember, it presents with like some psychiatric stuff. So that's how I remember that basal ganglia does emotions. When we decide to do anything, the thalamus is going to control basically what is accepted into the brain, into my processing, and then it's also going to accept what goes out. And the thalamus its job is almost always to say no, right? So its baseline mode is telling things no. The basal ganglia is going to modulate, particularly for movement, and that's what I'm going to cover now, how much the thalamus is able to say no, right? And so the direct pathway turns that off, right? So things tend to go more. It's pro-movement. And the indirect pathway tells the thalamus it's doing a great job telling people no, and it turns movement down. All right? It's the 500-foot view of this. I just wanted to point these structures out on imaging, and I can go through, right? So we'll pause here at the level of like the nose. I have this structure here with the cerebellum behind it, and I would call this the medulla. I think this is a contrasted study, so I would actually point these out as the carotid arteries on the side. Gonna let this run up. Whoop. We're gonna pause. We have these huge fibers feeding into the pons from the cerebellum behind. These are the middle cerebral peduncles. This little guy right here, I would call the basilar artery. The carotid arteries up front. We're starting to get some brain. We'll let it run a little bit. I know I said I was going to cover the basal ganglia, but this is good here. All right, kind of look like Mickey Mouse, right? So we have our Mickey Mouse ears with the cerebral aqueduct in the back. And we're much higher up. We're kind of at the level of our eyes now, the bottom of our eyes. Not that we're doing vasculature, right? But I wanted to just comment on the carotid arteries sort of form out into the MCAs. I'll let that run through one more time. Carotids, MCAs. Okay. So we'll pause at Mickey Mouse, right? There's our midbrain. I would call, not going to make that call. Maybe that's like a PCA right there, but great. Okay, let's get a little higher, a little higher. Okay. Lateral ventricles are like slits, typically, if things are normal. And then the third ventricle is like a credit card. I always think of it like the third ventricle it runs like this, and the lateral ventricles are like that. So I can see there's a couple rules that I use, right? So this is the lateral ventricle here. The caudate is always next to the lateral ventricle. So these are the caudates. This is the third ventricle right here that I'll put a blue kind of box around. And the thalamus is always next to the third ventricle. So if you're looking at the brain in cross-section like this, if you're looking at the brain in axial section, which is what we have, sagittal section, coronal section, this is what you have to deal with, right? So we're not high enough in the brain to really delineate all of the structures in the basal ganglia, but what I would tell you is this general rule: the caudate and the thalamus are separated from everything else by this white matter pathway, which is going to be the internal capsule. And then everything that lives on the other side of the internal capsule is going to be the putamen, and then going in the globus pallidus. And it's typically described as like an ice cream cone. So the cone is the putamen, the first, and then the ball on top of is the globus pallidus. And there's an external segment and an internal segment, and they sort of look like that. All right, I left the chat for a little bit. Cerebellum, peduncles, midbrain, PAG, pain, okay, great. Matt, I think you're just stream of conscious as we were going through the MRI, and I love it because that's exactly what I was doing. All right, I'll let this run through up to the top. You can sort of see but again, those rules about, right? So if I pause it up here and asked you what this structure is, right next to the top of the lateral ventricles, you would tell me it is. So lateral ventricles are always next to the caudate, and the third ventricle is going to be next to the thalamus. And so this gets spatially hard, right? Because the ventricles sort of like go like this in someone's head, and I can't really do it with my arms, right? And the caudate sort of just like hugs it the whole time, right? So as we see it up at the front, we see the head of the ventricle, the head of the caudate with the anterior horn of the ventricle, and then sort of the tail of the caudate runs all the way back. So this darker structure, but that's not where you're going to be asked. Great, and then, okay. Basal ganglia vasculature, you just need to remember lenticulostriate arteries, right? So if someone has an internal capsule stroke, anything that you're worried about, you just need to remember lenticulostriate arteries. And we talked about the lentiform nucleus, and so I think those two kind of play nicely together. So the internal carotid artery comes up, basically turns into the MCA, feeds off the ACA, and then the lenticulostriates are all of these. They're technically branches of the MCA, but I would remember them just as their own thing. Don't need to even worry about it. And yeah, I think remembering these as lacunar strokes is a really nice way of thinking about it. Okay. Took me a very long time to feel comfortable remembering this. I'm going to preface what I'm about to do is that I don't think it's imperative for you to memorize the direct and indirect pathways for step one, right? If I had to write 10 questions about the basal ganglia, 8 of them would be about pathology. 1 of them would be making sure that someone knew the indirect and direct pathways. And I would just say for most people, you can kind of calculate those odds and say, is it really important for me to spend a whole lot of my time doing this? I have a couple tricks that I think have helped me keep this relatively well sorted out. And I always draw it the same way. So I draw the cortex up top, right? That's just what we're planning. And I draw the thalamus, anything with the thalamus and a line on the side. So the thalamus and the subthalamic nucleus go on the side. And then from out to in, right? So the striatum, GPE, GPI, remembering the striatum is caudate and putamen, but they functionally do the same thing. So I lump them together, but don't worry about that. Striatum, GPE, GPI, thalamus. Memorizing the arrows and the directions is annoying. So I like motor tricks that help me remember things. Anything that comes from something that has thalamus in it is going to be stimulatory up and to the left. So I'm going to draw it in green because it's stimulatory. The cortex decides things, so it's stimulatory. Everything else is inhibitory, right? So anything that comes from this middle line is going to be inhibitory. Let's start with the direct pathway, right? If you are the striatum and your job is to get to the thalamus, right? And you only want to stop once, you're going to go directly to the GPI, GPI to the thalamus. Okay, I'll do the indirect pathway below. It's going to be indirect. You're going to pit stop. You're going to pit stop. That's it. So other tricks I think that are sometimes helpful to just cover here, right? So cortex to striatum. So if you think of this like a -1 and this like a -1, you inhibit the inhibition. -1 times -1 is +1. So this is going to be pro-movement overall, right? This is +1 times -1 times -1 times +1 if you're a math person. Down here, +1 times -1 times -1 times +1 times -1. That's 3 total -1s. So that's going to be a negative number. So this is going to be inhibitory to movement. So sometimes people like that trick. But if you lay it out like this, then you just have to remember that anything up and to the left from a thalamic structure is positive, and anything that originates in this middle line is negative, rather than looking at it anatomically correctly and trying to figure out where. I just prefer this. Some of you are going to say, well, what about the substantia nigra? The substantia nigra is, I always draw it in at the end once people feel like they get this, right? So we'll draw in the substantia nigra pars compacta. Through actions on the D1 receptor is going to facilitate, right? So this is going to be a positive on the D1 receptor. And then the D2 receptor is typically inhibitory, right? So it's a G protein coupled receptor and it's GI. So if you think about it, when we add dopamine into the mix, we add another like kind of negative here to the indirect pathway. So we go -1, 2, 3, 4, and that also ends up being pro-movement, right? So when the substantia nigra and dopamine are involved, they are pro-movement. Then we'll talk about, right, then you think about Parkinson's, right, where you sort of lose this. You lose a lot of your boost in order to be pro-movement. You don't lose everything because the direct pathway is still doing its job. You lose a lot of your boost. You lose a lot of your inhibition of the indirect pathway. All right, that's all I was going to cover for the basal ganglia. You can do more, right? I would tell you if you had to just guess, right, anything that's positive is going to be glutamate. Anything that's negative is going to be GABA. There are some neurons in the middle of the striatum that use acetylcholine, which is why you can use some acetylcholine. You can use some acetylcholine drugs in Parkinson's. There are particular like enkephalin neurons that leave the striatum in the indirect pathway that are broken in Huntington's, which is why Huntington's is a pro-movement disorder, because you preferentially destroy the indirect pathway. But, all right, I'm going to erase this in 5, 4, 3, 2, 1. Cool, so that's my trick. Hopefully it helps. Hopefully you don't need to use it. All right, I want to revisit dopamine pathways that we talked about earlier: mesolimbic, mesocortical, nigrostriatal, tuberoinfundibular, just to talk about two conditions that I feel like I always see questions on, and they're super high yield, and I wish we could talk more about them. But this is a good anatomic correlate, right? So let's talk about the primary pathology of Parkinson's, right? We don't have enough dopamine in the nigrostriatal pathway. We've lost our substantia nigra. It's a neurodegenerative disorder. We have a movement disorder because we're slow, we're bradykinetic, because we just don't have that boost that we need from dopamine. So we give them drugs like carbidopa-levodopa or bromocriptine, and we put more dopamine into their body. But then we suffer some consequences from that, right? We might level out the movement disorder, but we have some side effects, right? So too much dopamine in the tuberoinfundibular tract lowers prolactin, and that's not really going to be clinically consequential for us. This is where we're going to see kind of a big problem here, right? So people who have too much dopamine, so people, when they get started on some medicines for Parkinson's, can develop gambling disorders. People can hallucinate with some of Parkinson's meds, and they sort of can kind of behave in some ways that might be similar to someone who's living with schizophrenia. Where this becomes more relevant is when we talk about Parkinsonism as a side effect of schizophrenia treatment, right? So remember, the positive symptoms of schizophrenia are too much dopamine in the mesolimbic pathway, right? I'm hallucinating, having delusions. I have negative symptoms of schizophrenia because of too little dopamine in the mesocortical system. And I don't really think about the other two. But then I give somebody a dopamine blocker, right? So I give them risperidol and I block dopamine. And then it tends to improve their positive symptoms, right? It kind of blocks what we want it to block. So the positive symptoms go away. The mesolimbic system is better. The negative symptoms of schizophrenia very classically are not treated by dopamine blockers. That's because we're not really doing anything there. If any, I don't think we're making it worse, but we're not fixing it. We lower dopamine in the nigrostriatal system. We block it, so we get side effects like Parkinsonism and tremor, right? And then we block dopamine in the tuberoinfundibular pathway, which tends to give us increased prolactin. Just maybe I can convince you why you learned all of those dopamine pathways and why it matters and how it can be clinically relevant. I like to think about it like this. It's not typically taught like this. So if it doesn't mesh well with you, however you learned it best is going to be the best way. But maybe somebody's like me and likes arrows and tables. All right, I'm going to quickly go over vision. I wanted to leave time for questions about anything. If anyone have questions about the basal ganglia, recognizing there's lots and lots of pathology that I unfortunately was unable to cover. Oliver, with Parkinson from antipsychotics, what would you do? And a question, would you decrease the antipsychotic or would you add a dopamine agonist? Yeah, I would say the answer is usually going to be change the antipsychotic. There are antipsychotics that are more likely to cause extrapyramidal symptoms, and there are antipsychotics that are less likely, right? So if I have someone who has EPS on haloperidol, which is a high potency, I would switch them to something else that has less like risk of EPS, right? And so I think sort of the way this usually plays out on tests is they'll give you someone who's got multiple, and you get down to like clozapine, which has a really low risk of EPS, but has lots of other terrible side effects. So it's always sort of a waiting game. I would not give a dopamine agonist in that situation. Morteza, direct and indirect pathways for step 2. I'm never going to tell people to not know things. I might tell you that it's not something that I would anticipate being particularly helpful for you on step 2. Claudia would like the last slide one more time. I deleted it, unfortunately, but primary path, Parkinson's, down arrow, niger striatal, major side effect, hallucinations of, it fixes the movement, but then they hallucinate. Gambling disorders are super common, and I always thought that was very interesting. It's because of the nucleus accumbens, the dopamine pathway. Schizophrenia, really big thing is too much dopamine mesolimbic. We block it, which fixes it, but we also block it in nigrostriatal, and we cause Parkinson's. All right, I would be remiss if I didn't touch on vision. Eye movements, right? I think we've covered this, but cranial nerve 3, 4, and 6 are going to control all of these muscles, right? 6, lateral rectus, and then 4, the trochlear nerve. I find it less helpful to think about what the muscles do and more helpful to think about what happens when the cranial nerves break, right? So if cranial nerve 3 breaks, the classic description is down and out, right? So if cranial nerve 3 is lesioned, all we have left is cranial nerve 6, which pulls the eyes out, and cranial nerve 4, which does like a teensy little bit of a downward direction for us. So if we lose cranial nerve 3 on that side, right, the eye's going to go down and out. If we lose cranial nerve 4, we really actually lose only the ability to look kind of at our nose. So the classic description here is people who like fall walking downstairs or have trouble with that because they've sort of lost that. Kids who have cranial nerve 4 lesions will like tilt their head a little bit to like line their eyes up more because one's sort of down and in, so they'll tilt. And then 6, right, you lose the ability for lateral gaze. And then Ashen, dilated pupil with cranial nerve 3, most scenarios. There's one scenario where you do not have pupillary involvement. Can anyone tell me when you have a pupil-sparing cranial nerve 3 palsy? Not a lower motor neuron, right? If I wiped out all of cranial nerve 3, I would also wipe out the parasympathetics. Compression, so here, I don't have a slide on this, so let's go over it, right? So if I cut cranial nerve 3 down the side, the parasympathetic fibers tend to ride on the outside, and the motor fibers tend to ride on the inside. So if I compress, I actually dilate before the eye moves. If I have a stroke, right? So if I have low blood supply, right? So remember the artery is out here, and it kind of feeds blood in. So the classic scenario is actually someone with diabetes, has really small vessel disease. They have a stroke out here. It's insufficient. We get okay blood out to the parasympathetic, so I don't necessarily lose the dilation, but the motor stuff is gone. Yeah, so awesome, Matthew, microvascular. And then the comment on Edinger-Westphal nucleus, it's going to matter more for my light reflexes and not as much for my just dilation at rest. Tumor is going to act just like compression from an aneurysm. It's going to blow it first, and then it's going to move it. All right, and then just to name things that you'll see, saccades are our quick movements, right? So if I told you to look up, left, right, those are saccades. Your ability to track my finger is smooth pursuits, and those are mediated by different stuff, and you don't have to worry about it. So the eyes are up here, right? We have the optic nerves that run back from the eyes to optic chiasm, and then technically the optic tracts run to this pink nucleus that helps us with vision, and that is called what? So Will's saying MLF. Optic chiasm is this yellow one here. I know it's hard with this play button in the way. Pretectal nucleus, we're so close. Pretectal nucleus helps with light, not as much with vision. So the actual, like, you all are seeing my face in this picture right now. Good, Auburn, lateral geniculate nucleus of the thalamus. So the LGN, excellent. So the lateral geniculate nucleus of the thalamus is going to help with visual perception. It's going to send that information back to the occipital lobes, right, through these radiations. And so I'll play a video of them. MLF we'll talk about in a second. Chiasm is this yellow one. Pretectal we'll also talk about in a second. So if I play through this, right, it's kind of trippy to look at. But optic nerves from the eyeballs up here, optic chiasm, I'm going to pause. It's upside down. Just kidding, right? This is the top of the head. So I'm going to pause when I get here. Great. Okay, so optic nerves, optic chiasm, right, seen in cross-section, optic tracts. We can see a tiny little bit of pink there. It's the lateral geniculate nucleus, and it's going to feed that information back towards the occipital lobe through a superior optic radiation and an inferior optic radiation. You can see how this one's going to run up through the parietal lobe. This one's going to run straight back through the temporal lobe. So when I have parietal lobe strokes or temporal lobe strokes, I can impact those fibers, and it can cause visual changes. Great, and then this is sort of how it gets mapped out. There's a lot for vision. I feel like I could do a whole webinar on vision and eyes and stuff, but I just wanted to cover the pathway. You're going to be disappointed with where we stop there. Okay, pupillary light reflex. This is where pretectal nucleus and Edinger-Westphal, which people named. So I made this diagram a while ago. I see that Will is on the call. Will probably recognize, right? So light information is going to come in cranial nerve 3, and I sort of like this blue. I like colors, right? Blue is both. So light information is going to come in cranial nerve 2, make it to the pretectal nucleus, which is back here in the midbrain. The tectum is the back of the midbrain. So if you ever hear about the tectum, that's that area. That pretectal nucleus is going to send both Edinger-Westphal. Edinger-Westphal is just the name for a subnucleus of cranial nerve 3 that specifically deals with parasympathetic stuff. It's not a separate space. It goes right to where cranial nerve 3 kind of is. It just functionally has its own name. And then that is going to send it out both cranial nerve 3, right, and then sort of the pathway, the ciliary ganglion is the parasympathetic, and then out to the pupillary constrictor. So light in one eye is going to constrict both eyes coming out. All right, pretectal and Edinger-Westphal, I would remember in association to the light reflex. Lateral geniculate, remember in terms of vision, right? Auburn, I'm seeing, if you look at lateral geniculate, it spells glare back. Ooh, that's kind of cool. I like that. And then lateral geniculate does vision, medial geniculate does hearing and auditory perception. So those two tend to be more involved with, like, I think, like senses, whereas light is a little, I don't know, more obscure. Okay, someone mentioned this earlier, and I'm glad I have this video. This is the best video for this. It's frequently misunderstood what a relative afferent pupillary defect is, or a Marcus Gunn pupil. Basically, when you shine a light in the eye, it looks like that eye is dilating. So we're going to swing a flashlight between this eye is constricting. This eye appears to be dilating. No. Why is it not letting me? Great, I'll just talk while it goes. Constricting, appears to be dilating with light in it. Constricting, appears to be dilating with light in it. Constricting, appears to be dilating with light in it. Which eye is the problem? The left side of the screen would be the patient's right eye, the eye that dilates when light is in it, and the left eye appears to constrict. Yeah, it's the right eye, right? So dilating with light in your eye is abnormal, right? That's sort of, so basically what happens is the cranial nerve 2 on this right side is not as good as it should be. Doesn't mean it's totally broken, right? If I just tested that one and I didn't do the swinging flashlight, it actually might look okay. What happens here is that the information from cranial nerve 2, so these are cranial nerve 2, my 2 fingers, and then we'll say all the rest of the structures are back here with my thumbs, is slow. So when I come in this left side, everything dilates like it should, right? There's no problems. But then when I swing over to the right side, all of that information is slow. I'm already recovering from the other side. So it's actually gonna, like, paradoxically dilate. This is the most sensitive test for an optic nerve problem. If you want to not understand it and you just want to have like a buzzword, if you see this, like the optic neuritis and like MS is where I would go with my brain. I can play it one more time. You can also look up this video. This is an excellent video from the Michigan Eye Center. It's on YouTube. So looks like it constricts with light. Looks like it's getting bigger and dilating, which is abnormal. And the only way you can test for this is by swinging the light between the two. All right, we talked about pupillary light reflex. So I just want to touch on the last reflex. I have 2 more slides. Appreciate. Coma is what we just use when we have no arousal and no awareness, right? We don't participate with our environment. You'll learn about the Glasgow Coma scale, which is commonly used in like trauma scenarios to provide objective information on the overall level of responsiveness, right? So what do their eyes do? What do they do to voice, right? What do their movements do? For step 1, you need to just know the anatomy of the brainstem reflexes. Pupillary light, cranial nerve 2 in, cranial nerve 3 out by way of the Edinger-Westphal nucleus. Corneal reflex, right? We talked about sensation for up here is going to be through V1. To close the eyes is going to be the facial, right? The orbicularis oculi is that closing my eyes. So that's going to be 5 and 7, particularly V1. Vestibulo-ocular reflex is also something you'll see tested, right? If you all were trying to watch something and your head was turning, you can typically keep your eyes on it. And that's because you get information from your vestibular system that you can follow and it feeds towards your eyes. So sometimes when people can't move their eyes when you ask them to, you move and see what their eyes do. And that can tell you, is cranial nerve 8 communicating with the eye movement system? Cough, we talked about, afferent is 9, efferent is 10. I'm sorry, gag, afferent is 9, efferent is 10. Cough, I think sometimes first aid listed as 9 and 10. I typically just think of it as 10 only. The idea of that being an important distinction to make for any of you is quite low. Posturing, we talked about the midbrain. Clinically, I don't use the word decorticate or decerebrate posturing. I tend to just think it's way easier, flexor or extensor posturing. People don't like remembering these. A couple tricks. Decerebrate has more ease, so it's extensor posturing. Decorticate points towards the cortex. It's flexed, so the arms are pointing up. Those are the 2 that I know. These localize. Decorticate is anything above the red nucleus, right? And then decerebrate is typically at the level of the red nucleus or slightly below. That's why the red nucleus matters. I said I would talk about it previously. So right, we're in the midbrain, spaced repetition for the midbrain, right? I would draw on the substantia nigra right here, red nucleus, motor pathways are up front, medial lemniscus, spinal thalamic, cranial nerve 3 is in the middle, and 4. All right, that last bit was a little bit of a whirlwind, just on like, I knew I was gonna be over an hour, but all right. Let me clear my screen. And so you can see that what I talked about earlier, right? We all love what we do here. We like to teach. Sort of other things that we just do very successfully through MST is help people with just scheduling and planning, and as well as I think just being really adaptive to exactly what people need. I have tons of students where I just do questions with them, some where I teach in similar ways to this, sort of help you navigate all of the aspects that go into succeeding on these tests, recognizing it's more of a wraparound service than just teaching you science. And then other services, right, offered through the company, I think are just worth mentioning, right? Just, hey, I just really I need just a little bit of help with direction, right? So some strategic planning, and then things like applying to ARIS and moving on. So I will answer any questions. I think I kept up with the chat. All right, so Will's question, is that like central pontine myelinolysis? Not particularly, right? So central pontine myelinolysis is So in the pons, right in the front of the pons, the corticospinal fibers go down. And then there are other fibers that sort of like encircle them from this direction. If someone has low sodium and you correct it too quickly, these crossing fibers will swell and pinch off all of the descending motor fibers, and then that person will be locked in, right? The eyes will be okay because the eyes are above the pons, right? 3 and 4, vertical eye movements will be fine. All of the motor fibers for the whole body will be impacted. Man in the barrel is typically the description, make sure. Example for decorticate and decerebrate situations. Again, stroke of the midbrain at the level of the red nucleus is really the decerebrate option, the extensor posturing. Decorticate can be anything above, right? So typically sometimes if someone's coming in from an ambulance and or someone who's had a stroke in the past can also be helpful, right? They tend to be contracted, right? So their arm tends to be bent in like this in flexed posturing. So if someone's had an old stroke, that's not really decorticate posturing, but it might be helpful to think about it that way. So it can, in acute situations, do that. But anything above that that impacts motor fibers, man in a barrel is the classic description for a watershed infarct, right? So an ACA, MCA territory, like watershed. Man in the barrel will preferentially affect proximal muscles more so than distal. So people will be able to like move their hands and feet, but not really their shoulders, like they're stuck in a barrel. Auburn, nice motorcycle going by. Auburn, I was reading it, better to comment on the palatal elevation, the uvula being midline or whatever, give me your knowledge focus. I normally say palatal elevation. I don't know why. I normally do. Maybe people, I have my uvula deviates midline and I'm not currently having stroke. I don't think. But yeah, I normally say palatal rise. Coma warm water test. Okay, so you're talking about calorics. That is a way of sort of trying to stimulate the vestibulo-ocular reflex. I would maybe think of them more or less the same, right? Me jolting someone's head should make their eyes move, right? Because we talked about how, like, if you put hot water and you turn all of those nerves on, or the opposite, cold water and turn all of those nerves off, that should give the same impulse of head movement, which should cause, but if I would not spend a lot of time memorizing cold calorics and hot calorics, just in general, right? Turning nerves on or off in the ears is going to send vestibular input to the eyes, which is going to make them move. Think that your head is spinning. I had a great time doing this. I hope this was helpful. With that, I'll let you all enjoy the rest of your evening. Thanks so much for being here.